Hello, I'm Dr. Jean-Pierre Bassand from the University of Besançon in France. Today we are going to discuss antiplatelet therapy in acute coronary syndromes and the outlook for 2012. So welcome to this session. Today I'm joined by two distinguished cardiologists in Europe, Dr. Peter Clemmensen from Copenhagen University Hospital in Denmark, and Dr. Jean-Philippe Collet from Hôpital Pitié-Salpêtrière in Paris.
Hello.
So, my dear colleagues, I suggest we address a few issues, and I would suggest we start with antiplatelet therapy, what has been shown in 2011, what we can, let's say, see for 2012, the new therapeutic that may be implemented in 2012. We may keep going with anticoagulation and finish about primary PCIs and new anticoagulants in this setting. So let's start with antiplatelet therapy. And it's fair to say that the landscape, the background therapy has changed quite a lot during the last years. In the past, we had dual antiplatelet therapy with aspirin plus clopidogrel. And now we have two new P2Y12 inhibitors, namely prasugrel and ticagrelor. And I would love to have your opinion on how to deal with these new, well, we do not question the need for dual antiplatelet therapy, of course not, but how do you foresee we could use these new drugs, prasugrel and ticagrelor, in the setting of acute coronary syndromes, whatever it is, with or without ST segment elevation? Who wants to start? Maybe Nobel
He's our
foreigner.
Guest. Yeah.
You're our guest, please, Peter.
Okay, I'll try to give it a shot. It's true, it was so easy for many years because we only had, one drug that we had to give on top of aspirin in acute coronary syndrome, and certainly also in stenting patients with coronary artery disease. But now the scenario is completely different. And I think what we have are two good alternatives. Not only alternatives, but they're actually superior in two different trials of somewhat different design. They have shown to be superior to clopidogrel. So I think we are now in 2012 at a time where we need to change. And we need to change for certain patients. And it must be up to the doctor, and it's a very difficult choice which drug to choose. So to be very pragmatic, I think that all ACS patients should be changed now to one of the new drugs. I think also, of course, the patients who are on clopidogrel and experience a stent thrombosis, and those who are intolerant to clopidogrel should be shifted to the new P2Y12 inhibitors. So the big question is, which one to choose? Why not be defensive and say that in my own country, there's actually an alternative? So the way the Danish guidelines have been written on this subject is that you have the alternative in both STEMI, non-STEMI and unstable angina, to choose either prasugrel, which was the first one to appear on the market, or ticagrelor. In reality, the guidelines could be read that ticagrelor is the preferred drug because it's mentioned first in every single line. And also, it has the ease because the Plato trial, or an ease of application because in the Plato trial included all patients no matter what the final treatment was. So medically managed, those who were underwent angiography or eventually PCI and even bypass surgery to a big extent in 5% of the patient. So it's sort of a real world experience. And that's also what we've seen happening in terms of implementation in my country. Although prasugrel is being used and has been used quite extensively, especially for STEMI and diabetics.
Yeah. Jean-Philippe, I'm sure you would like to challenge a little bit the opinion of Peter.
Sure. Well, I would be also very pragmatic and on the ground. So we have not ticagrelor, on the market released yet. So we are just sticking with prasugrel. And the experience we have is that it's a useful drug for primary PCI and for diabetic patients because those are the patients who display the greatest benefit. And my perspective for ticagrelor is that it could be used in those fragile patients who are not eligible for prasugrel. Renal failure patients, those with who are medically managed, those who are very old or with stroke. So I think that they will find their place, on the side of prasugrel, no matter. My concern is another one. It's 2 points. The first one is overtreatment, and the experience that we have with prasugrel is that about 1/3 of patients are overtreated with 90% inhibition, after 1 month of exposure. And what is rational for having these patients with such a high level of inhibition, for 9 more months? I think it's a real concern.
That's a good point.
Yeah, and the second one is primary PCI. These are, orally given drug. And in primary PCI, what you want is to have a very fast, effective drug. And my concern is that when it's orally given, there is a real, it's not a very fast onset as we think it is. And we need to have trials to see what is the real picture of the efficacy of this drug in the context of primary PCI.
So, well, I have a question for the two of you. Ticagrelor, in your opinion, should, let's say, bridge the gap left open by prasugrel, indications where prasugrel doesn't fit. But actually, ticagrelor covers the whole spectrum, including unstable angina, non-S elevation acute coronary syndrome, S elevation myocardial infarction, PCI, primary PCI, CABG. All the spectrum is covered. So it's quite clear that it could be given to any kind of patient. There is clearly an homogeneity in the response irrespective of subgroup you can consider, diabetics and renal insufficiency, etc. So to my surprise, I see that sometimes people are reluctant to, let's say, adopt or read the results and accept the results. And there is a major, let's say, outcome with ticagrelor, which is significant risk reduction for cardiovascular death. So how do you, let's say, how do you put this risk reduction in cardiovascular death in a picture, in a gross picture? Personally, I would tend to support the use of a drug with a clearly demonstrated risk reduction for death, which is the most important outcome to me.
Well, I agree. It is impressive. I think that partly it's explained by the sheer size of the trial. It was a larger trial. There were, at least in subgroups, the same signal in the Triton TIMI-38 trial for prasugrel. So I'm not sure that they're all that different, really. I mean, they're simply two more effective ADP receptor antagonists, which is shown also by the slight increase in bleeding risk seen with both drugs. But certainly, the observation of a decrease in cardiovascular mortality, of course, is impressive. And I think that leads many cardiologists to choose a simple algorithm. If you had to write new local guidelines and you want the youngest doctor, the medical students to understand what's going on, I can see why favoring that some of my colleagues have chosen to favor a very simple protocol of what's called, one drug fits all, ACS, because it does become complicated, even in my own institution, where we also have prasugrel for STEMI and diabetics, because there are issues with the elderly and the lightweights under 60 kilograms who needs a decreased dose of 5 milligrams each day. Those we actually have in the past treated with a 5 milligram, although sort of lack of data. These are computed data, or the dose is based on computed data. And we actually shift those to ticagrelor. And, I would gladly accept the argument that why on earth do you do that? And partly it's because of tradition. We have been using prasugrel for 2 or 3 years now for STEMI. And it just makes sense not to succumb the patient to this risk. However, I must say that you say the medically managed, there's a big trial coming out now, Trilogy, maybe going forward public in the Munich meeting, ESC, in the medically managed patients using prasugrel versus clopidogrel with a long exposure time. And also, for the first time, we have a prospective use of the 5 milligram dose in a medically managed population above the age of 75. So that would be extremely interesting.
No doubt. The results of Trilogy are eagerly awaited. We do need these results quite quickly. But you used a word that I like in your speech. You say, well, it becomes more complicated. But it will be possibly even more complicated in the future because we are talking about P2Y12 inhibitors. But there are new drugs under development which target other receptors, and particularly the thrombin receptor antagonist, and Vorapaxar particularly. So, Jean-Philippe, how do you foresee, suppose that TRA2P would turn to be positive with no excess of bleeding, and how do you foresee the use of these drugs that would be an add-on? So we'll go for, do you believe that the clinicians are ready to go for triple antiplatelet therapy?
For antiplatelet therapy, I think the answer is clear, it's no, because of the excess of bleeds. But I think that we're at a stage with lots of new drugs, and I think that our task now is to play around with the drugs and to find what is the best combination. Maybe we should get rid of aspirin and combine these new, therapies, and see what is the best for subgroups of patients, especially those who are old and weak, fragile. And I think we have lots of additional work to do with these new drugs, and this is the future of the clinical research for the next 10 years. Mm-hmm. And I think we won't have new drugs on board, but we will have to look for the best combination.
But in terms of combination, our task might become even more complicated if we consider now the new oral anticoagulants. In this regard, we have very conflicting data. Actually, there are not so much conflicting between the results achieved with APRAISE-2 and apixaban, and on the other hand, ATLAS-2 and rivaroxaban. You know the results, of course. But what is your interpretation of this discrepancy? Who wants to start with? Jean-Philippe, do you want to?
Sure. Well, I think that the first study, which is ATLAS, is the first demonstration that triple antithrombotic treatment is better than dual antithrombotic treatments in the secondary prevention of ACS. And I think it's the first study to show that. Yeah. The second point is that it's like a cooking recipe. So we have the drug, we have the context, and we have also the study population. And in the ATLAS ACS, it was post ACS at intermediate risk in terms of ischemic and bleeds. And the drug, which is an anti-TNA, the rivaroxaban, was used at a very low dosage. It was either 5 or 10 milligrams. And it turned out that the lowest dose, which is only 1/4 of the dose that is used in atrial fibrillation, turned out to be very effective, because there is a reduction of mortality, cardiovascular mortality, and also a 40% reduction in stent thrombosis, which was unexpected, and a very good safety profile. Whereas with the high dose, there is a safety concern with more intracranial bleed. Whereas with the APRAISE, the population was different. Higher risk, higher dosage, 5 milligrams twice daily, and the trial was stopped prematurely due to safety concerns.
That's always the same. In a phase 3 trial, the most difficult, very often the most difficult, is the selection of the dose. And clearly the dose in APRAISE-2 was too high, and that's the reason. So now, Peter, given the results of ATLAS-2, where does it fit, this rivaroxaban? Are you ready to go for triple therapy with aspirin, P2Y12 inhibitor, and again, this was not ticagrelor or prasugrel, but clopidogrel in ATLAS-2, not the new P2Y12 inhibitors. So are you ready to prescribe all these 3 drugs together?
Yes and no. And you actually, you sort of came before me in actually preparing my answer. I think that the huge challenge here is that these were done in a context of aspirin and clopidogrel, and not the new P2Y12 inhibitors. I think that's one of the biggest limitations to these new studies, because, frankly speaking, they should be redone in a modern era, which is unlikely. which is highly unlikely.
Yeah, I agree.
Probably not to be done. And I think that actually it's probably too detailed. I think when you look at these studies, if you look at the bleeding incidence in these two studies, they were not that different. So I think when you sort of scratch the surface a little bit, I'm really not so sure these two results were that different. You know, one trial was stopped because of bleeding, the other one continued, and of course they hit a sweet spot in terms of the dosing. So I think this is interesting, and I'm sure it will find the place. To be honest, I have not yet find out what the place is going to be in my practice.
Yeah, I agree with you, but in the appraise too, the new P2Y12 could be used, and this also might be a cause for the excess of bleeds, you know. And I think that clopidogrel remained the most widely used drug, even in ACS patients, because if you look at STEMI patients, it's only 40% who are getting the new P2Y12. So I think there is still a room, you know, for this kind of combination. And
a good point.
Yeah.
I guess that clopidogrel is here to stay. It's an imperfect drug, no doubt, particularly vulnerable to genetic variation. We all know that, but it's here to stay, and particularly in Europe. You know, we are living in Western Europe where access to drugs is quite easy, but the price matters in many other countries, particularly in Eastern Europe. And for simple matter of availability of the new drugs or price of the new drugs, given the fact that clopidogrel is generic now,
it's very cheap.
It's here to stay, I believe.
I agree.
So,
I agree.
My dear colleagues, time is running quite fast, and we still have one issue to address in, if possible, 3 to 5 minutes. Primary PCI. Is there something new on the horizon? I mean, I'm just playing on the words, and we have got horizons quite some time ago, and very convincing data with bivalirudin versus conventional antithrombotic therapy. And now we have yet another trial, ATOL, which tested a completely different compound. And I believe that Jean-Philippe Collet is probably the best to answer first.
I would agree.
Thank you.
First, I said, because he was deeply involved in ATOL. Jean-Philippe.
Well, both trials are very interesting because there is a mortality benefit, and we are, you know, in a context of primary PCI, the one where, you know, PCI is the most effective, and the trials are quite different because in the ATOL it's a more contemporary trial. You have lots of radial approach, lots of GP2B3A, all patients who are naive, 95%, so no pretreatment, very few crossover. So very consistent treatment.
Naive of what?
Anticoagulation, which makes a huge difference.
Right.
In terms of bleeds. And I think that the major results is the first, on the primary endpoint, the study is negative, I agree, but it was a weak endpoint. But if you look hard endpoint, like DSMI, you know, cardiac arrest, there is a 40% reduction. And if you look at mortality, there is also, you know, a reduction in mortality, whereas the safety profile is exactly the same. Whereas in the horizon, there is more pre-treated patients, you know, a lower rate of patients with, you know, clopidogrel at the time of PCI, and most of the benefit is driven by the safety profile of the drug. So we need, you know, probably a third trial with head-to-head comparison between bivalirudin and, you know, enoxaparin, but I think it won't happen. But it's very interesting, and again, it's the anti-TNA with the you know, enoxaparin drug, which has a huge effect on ischemic events.
And again, in horizons, well, I mean, with bivalirudin in the setting of primary PCI, the first 48 hours regimen is poorly defined because it was clearly shown in horizon that there was an interaction between pre-treatment with any form of anticoagulant and clopidogrel dose. It's quite clear that bivalirudin alone was not able to prevent stent thrombosis because this, let's say, the marketed antiplatelet effect of bivalirudin is probably negligible, if
it's
any.
Not big. Yeah.
I agree.
Would you agree with the comments of of Jean-Philippe Bassand?
I always agree with Jean-Philippe on most things, but a few details. I think in the way that primary PCI is practiced in the Nordic countries, at least, there's a huge contingent of patients who are pre-treated already in the ambulance aggressively with heparin and also with prasugrel and clopidogrel in the past, and even most recently with ticagrelor. So I think this is the real world to us. Regarding the stent thrombosis early on in Horizons, that is in an ongoing trial with pre-hospital bivalirudin versus conventional therapy called Euromax being sort of tested. And the way we try in that trial to overcome is to have a continuous infusion of bivalirudin in reduced dose in 4 hours after termination of the primary PCI. But I think this is interesting, and again, let's do the trial and see which one works best. I would love to do it.
Yeah.
We know that the Danish people, the Danes, work quite well in clinical trials. They include a lot, and they do a fine job. I would love that our country would do the same. But anyway, it was a word to finish, to conclude our session. Thank you very much, gentlemen.
Welcome.
Peter and Jean-Philippe, you were not good. You were excellent, as usual.
Thank you.
And thank you for joining us today.